Good morning and welcome to our diabetes webinar in partnership with St George Hospital. I would like to welcome today's speaker, Associate Professor Terrence Diamond, who is a staff specialist with the Department of Endocrinology at St George Hospital and has over 30 years experience in clinical diabetes. Also joining us is Denise, who is a clinical nurse consultant for diabetes and who will be facilitating the Q&A today.
Diabetes is an epidemic globally worldwide, which will increase by about 51% until we get to 2030. I'm not sure we'll be green by then, but there'll be a lot of diabetics around. And it's calculated that probably about 6 million diabetics were missed during the COVID epidemic. On the theme. So when we look at diabetes, I've kind of thought about it in this kind of 4x4 box, where you have individuals with diabetes who present either with obesity, and that's in the left vertical column, or metabolic syndrome, and that includes other risk factors such as hypertension, dyslipidemia, and smoking. And so if you have individuals who do not have obesity and do not have metabolic syndrome, and they've got diabetes, they may have some rare form of genetic diabetes, or they have really a low risk of atherosclerotic vascular disease and CKD. On the other hand, if they have no metabolic syndrome and they have obesity, then I call them the happy fatty chappy, which because of their adiposity. On the other hand, if you have an individual who has evidence of metabolic syndrome and is not obese, and we often see that in the thin Asians who really have a different type 2 diabetes, which we don't understand, they have a moderate cardiovascular risk. And then the ones that are the highlight are these very high risk obese individuals with significant metabolic syndrome. And so the treatments are aimed at these different quartet that I call adiposity being a driving factor or vascular disease being a driving factor. So as you're well aware that the incidence of microvascular and macrovascular disease is very high in type 2 diabetics, with 50% having retinopathy, 35% having nephropathy, high risk of stroke, cardiovascular disease, and diabetic neuropathy. And this just shows you some data looking at the different complications of diabetes, all-cause mortality, non-fatal, fatal stroke, and congestive heart failure. And as you can see, as the hemoglobin A1C increases from less than 6% up to greater than 10%, you have this fourfold increase in diabetes-related complications. So glycemia and HbA1c does seem to be a determinant of outcomes. Just the other point that I want to mention is that you often don't see very good outcome studies in stroke. And as you can see here, the incidence of stroke is much lower compared to, for example, cardiovascular disease. So my case for you this morning is a 70-year-old female who presents with type 2 diabetes for the past 6 years. She's been treated on combination therapy with metformin and Novamix, and has been receiving rosuvastatin and ramipril. She has a BMI of 31.4%. She's gained about 12 kilograms over the past few years, has a blood pressure of 135/90, an LDL cholesterol of 3.8 millimoles per liter, and an HbA1c of 8.2%. And she has evidence of stable ischemic heart disease, having undergone previous percutaneous angioplasty, and has evidence of stage 3 CKD. So I'm sure you all agree that this is a very common patient in most of our practices. So my questions to you this morning, and I hope to answer some of them for you, is number one, is she insulin dependent? 2, is her diabetes reversible? 3, what is considered the most appropriate anti-diabetic therapy for her metabolic syndrome, cardiovascular disease, and chronic kidney disease? And what would you consider as an ideal glycemic target in this individual? So the first thing, is she insulin dependent? And that will depend on what the residual beta cell function is, an underlying cause of her diabetes. So this complex slide you'll hate, but it's not so complex. And what it does is to try and explain to you the relationship by looking at insulin, C-peptide, and blood sugar levels, and you can measure those. And in fact, you can order from any pathology a HOMA test, and that works out the glucose utilization or disposal. So if you go to the graph over here on the vertical axis, you can see the insulin release, and on the lower axis, the insulin sensitivity. So if an individual has a very low insulin level, you can see they are in the diabetic range. And that's really not influenced that much by their insulin sensitivity, because they've passed that, their beta cell function has failed. If they have significant insulin resistance, and you all like to measure insulin, they say they've got hyperinsulinemia, well, that means their insulin levels are elevated, and it will depend on their glucose disposal. So if they can get rid of glucose, they'll have high insulin levels and increased insulin sensitivity, and they'll have normoglycemia. But if they cannot get rid of glucose, so they have less insulin sensitivity, then they progress down the IGT diabetic pathway. So the natural history of diabetes then is usually from the time of diagnosis, a majority of our patients already have underlying micro and macrovascular disease. The disease starts often 10 years prior to presentation. And as you can see, that the fasting plasma glucose is the last to go up. The postprandial goes up. And what you have early on is this discrepancy between the insulin secretion and insulin resistance, where initially they're both high. When once you start getting beta cell function, the insulin secretion drops off. So if you're going to treat someone and hope to get some reversibility, you want to get it before, as I showed on the last slide, the insulin levels are too low. Now, it's important to remember that not all type 2 diabetes is type 2 diabetes. And that's important because when we look at reversibility, we want to know what we're dealing with. So LADA or latent adult onset type 1 diabetes are elderly individuals. They can be 50, 60. So not like the classical young child or 20 to 30-year-old. And they have positive GAD and IA2 antibodies, which confirm that they are LADA. And they're pretty difficult to treat. You can have the genetic defects of beta cell function, that is the maturity onset diabetes of youth, or MODY, where there is an abnormality in insulin secretion due to abnormal signaling. Disorders of pancreatic function are very important and should always be excluded. Whenever you find a patient who has deterioration in diabetes that you cannot explain, you must exclude underlying pancreatic carcinoma. But other causes such as calcific pancreatitis, cystic fibrosis, and hemochromatosis are important. Do they have underlying endocrinopathies? Look for clinical features of Cushing's syndrome, acromegaly, polycystic ovaries with acanthosis nigricans and hirsutism, the pheochromocytomas, and rarely glucagonomas, which present with a bad rash. Drug-induced causes, the commonest being corticosteroids, congenital infections, chromosomal disorders such as Prader-Willi, Klinefelter's, and then gestational diabetes. So you really need to kind of, in your mind, formulate whether the patient has just unexplained polygenic type 2 diabetes, or have they got an underlying secondary cause. So is her diabetes reversible? Well, what is the natural history of diabetes and beta cell function? And what I've shown you on this cartoon is the beta cell function measured by HOMA and the years since diagnosis from impaired glucotolerance, postprandial hyperglycemia, and type 2 diabetes. And as you can see, from the time of diagnosis, you start losing beta cell function, and then the individuals initially on diet, then monotherapy, then combination therapy, and then insulin therapy. And these data have clearly been shown from long-term randomized controlled trials, such as the UK PDS trial for type 2 diabetes, where individuals remained on diet for 6 years. Well, let's talk about reversibility and what do we mean by that? And we'll just stick to the bottom three disease states. We won't talk about type 1 diabetes. So in the first major column, we have normal glucose regulation. We have impaired glucose regulation, And then we have diabetes, which may be non-insulin requiring, insulin requiring, or insulin requiring for survival. And what you can see here, there's an individual with type 2 diabetes who will progress, but can they go back to normal glycemia? Other specific types, individual who may have normal glycemia or impaired glucose tolerance, goes on to corticosteroids, becomes diabetic, removal of corticosteroids, they can reverse almost back to normal. And the classical one is gestational diabetes, where they have genetic predisposition probably, and they become pregnant, they develop insulin resistance, become diabetic, either insulin or non-insulin requiring, and once they deliver the baby, they return back to normal. So this clearly shows you that there is reversibility. So this is our patient, and these are investigations. She had a fasting blood sugar done following withdrawal of her therapies for 24 hours. And you can see she has an elevated fasting plasma glucose, an elevated fasting plasma insulin, and an elevated C-peptide, suggesting that she's insulin resistant and probably not completely beta cell depleted because her insulin levels are still elevated. LADA was excluded by negative GAD and IA2s, and secondary causes were excluded by urinary free cortisol, metanephrine, and a tumor marker for pancreatic carcinoma. So what is the most appropriate therapy for her type 2 diabetes? Remembering she has obesity, atherosclerotic vascular disease, and chronic kidney disease. So the natural history in our practice is that it takes about 10 years for individuals in the past to be ended on combination therapy, and that they would go on diet, they'd fiddle around with the old oral hypoglycemic agents we have, and then eventually they would start an initiation of insulin. And by that time, they often have significant diabetes-related complications. What we learned from the UK PDS study is where, and this was a 12-year study and then extended, where individuals were randomized to diet or intensive pharmacological therapy. And what we saw is that, yes, there was a reduction in myocardial infarction, hazard ratio of a 15% reduction over the period of time. And that was related to the difference in the HbA1c between those that were intensively treated in the orange versus those that were conventionally treated, and that extended over the 15 years. However, what you note in the study is that the HbA1c continued to increase. And that is probably because if you look at the weight gain, a similar factor happened. The more insulin they get, the more weight gain they get, the more insulin resistance they become, and you end up with HbA1c drifting up. So this has been a fundamental flaw in our management of diabetes, and it always bothered me that the drugs we used never achieved the true treatment for insulin resistance. You're aware of all the agents that are around for the treatment of diabetes, the GLP-1 receptor agonists, DPP-4 inhibitors, the thiazolidinediones, which used to use the SGLT2 inhibitors, metformin, and then insulin and drugs which enter centrally. So what I want to do is to show you how these drugs may cause improved beta cell secretion and improve insulin sensitivity. So on the cartoon I showed you initially, this is the beta cell response, insulin secretion. This is the insulin sensitivity. And so individuals who are in this region where they have hyperinsulinemia and poor insulin sensitivity, you want to drive them out and try and reverse their type 2 diabetes. So effective weight loss therapy for patients with type 2 diabetes and obesity. And this is where we learn the message. We learn the message from bariatric surgery. This is a study which was recently published in Diabetes Care, where weight loss achieved remission of type 2 diabetes. Patients were treated either by gastric bypass or sleeve. There were over almost 6,000 patients, mean age of 49, majority of female, and they were pretty obese. They're 43.8 kilograms per meter square. They were followed for 5.9 years, and 71% achieved an initial remission of diabetes. The average time to remission was 1 year, and the retention rate was 82%. And what this study showed, that the remission was totally dependent on the weight loss. So that patients who achieved the weight loss of 15 to 20% total weight loss were 2.3 times more likely to remit. And patients on insulin at the time of surgery with greater than 20% weight loss had a 2.1% times of remitting compared to those who were not on insulin. So I want you to think about that, because we have a lot of patients on insulin who may not be on insulin. And I would say that over the past 12 months, where I used to put 2 patients a week on insulin, I'm probably taking 2 patients a week off insulin. Now, that is due to the discovery of these new agents, which I really think are absolutely amazing. So I'm going to discuss them in a little bit of detail. And we're going to talk about the GLP-1, glucagon-like peptide 1, which is secreted by the ileal cells in the gut, and the GIP, which is glucose-dependent insulinotropic polypeptide, which are secreted by the cells of the duodenum. So what this cartoon shows you is, first of all, the arterial plasma glucose. And whether you give it intravenously or orally, you will get an abnormal curve, a diabetic curve. Now, what is the difference in the insulin levels when you give it orally or intravenously? And you can see intravenously, there's very little change in the insulin levels, but when it's administered orally with the oral glucose tolerance test, you have this incretin effect. You have a much higher insulin release. So this is telling us that the gut is controlling the insulin release. And the difference between the two is the incretin effect, and can be expressed in a percentage. So I want to take you through this complex slide, but it's very important for you to understand how GLP on the left and GIP on the right, how these drugs work. So GLP first, it acts on the central nervous system to increase satiety. It decreases food intake, results in body weight, but there's associated nausea. It increases pancreatic glucose secretion. It reduces gastric emptying. And by all that on the liver, it improves insulin sensitivity and decreases hepatic glucose production and lipolysis or lipotoxicity. And overall, it will reduce hypoglycemia. GIP receptor agonists, on the other hand, they do the similar thing, except they cause decreased nausea. So they may combat the effects of the nausea that you're seeing with GLP. They increase both insulin and glucagon, but very, very importantly, because we learned this from the thiazolidinones, the drugs that we used to use but cause fluid retention and heart failure and were ceased, and they improve in fatty tissue insulin sensitivity, lipid buffering, and the pro-inflammatory cytokines such as the adipokines, which causes insulin resistance and specifically hepatic. And then their effect on the skeletal muscle is improved insulin sensitivity, and overall they cause hyperglycemia and decrease dietary triglycerides. Now, what I'm going to spend the next few minutes is going through the drugs which are GLP agonists, which we know, and we'll come to them a little later, and the new agent, which is both a GLP and a GIP receptor agonist, which has been registered on the FDA this year. And this is a new drug, which is a chimeric drug, which acts on both the GLP and GIP receptor to improve insulin secretion and glucose tolerance and cause body weight loss. So what data do we have? Well, first of all, the goal of therapy to achieve remission of diabetes is to achieve an HbA1c of less than 6.5% with a body weight loss of approximately 10% and no hypoglycemia. And we are very fortunate to have published over the last year or two the SURPASS studies 1, 2, 3, 4, and 5. And they're very similar, but I'm going to go through them in a bit more detail. So these individuals in the studies had diabetes ranging between 4 to 8 years. They had a BMI of roughly in the 35%, and their HbA1cs were roughly in the 8%. And so the first study was comparing this new combined drug tirzepatide versus placebo. The second one was comparing tirzepatide to semaglutide, as you're well aware, Ozempic. The third study was comparing tirzepatide to insulin degludec. The fourth study was comparing it to insulin glargine in patients with increased cardiovascular risk. And then the fifth study was comparing it to multiple combination therapy. So when you look at the slides, you're going to see that we have those different conditions on the slide. The important thing using tirzepatide is that it's a slowly uptitrating dosage every 4 weekly. And so there's a 5 milligram, 10 milligram, and 15 milligram dose, which is slowly escalated. So let's go first. What is the key findings of these studies? Okay. The mean baseline body weight, as I said, was 85 to 95 kilograms. These are the 4 studies. And what you can see is using this new agent, they achieved a weight loss of about 9.5 kilograms versus monotherapy metformin 0.7 kilograms. In the add-on SURPASS study with metformin compared to semaglutide or Ozempic, you can see this is obviously a dose-dependent increase in weight loss from 7.6 to 11.2. That is 12% body weight compared to the drug we use now, which gives about a 6.1% body weight loss. When compared to the insulin add-on with SGLT and metformin, you see an even more striking weight loss of 12.9 kilograms or 14% compared to the weight gain on insulin. And similarly, when you have a multiple add-on compared to glargine, you see the weight loss compared to the weight gain on insulin. So you can see from these studies, they were approximately 12 months. Now, what about patients achieving a weight loss target of less than 10%? Well, as you can see in all 4 studies, 70 to 80% of patients achieved the appropriate weight loss goal compared to either monotherapy, compared to metformin, semaglutide, compared to combination therapy with degludec, and compared to glargine. 80% of patients achieved adequate weight loss. Absolutely amazing. Well, what about the changes in the HbA1c? So again, the similar cohort, and you look at the changes in HbA1c versus monotherapy, 2% change versus no change versus monotherapy versus metformin, semaglutide at 2.3%. I mean, semaglutide is pretty good, 1.9%, versus degludec insulin, 2.3% versus 1.3%, and multiple add-on, 2.5% versus 0.93%. Again, a far superior decrease in the HbA1c, which mimics the optimal achievement of weight loss. Now, what about achieving, this is total remission. We're talking about an HbA1c of less than 5.7%. And that is, just unheard of. And as you can see over here, the studies on the left, similar thing. And if you look at the final column, that's those individuals achieving the primary endpoint, which is dose dependent, you can see that it ranges in the high dose from 50 to 60%. That is just amazing. And I think will change the management of diabetes forever. Okay, so what about the effective therapies then for patients with type 2 diabetes who present with atherosclerotic disease or CKD? So just to remind you that often patients with type 2 diabetes have underlying vascular disease, and that in those with diabetes compared to no diabetes, there is a marked increase in the hazard ratio in angina, unstable angina, non-fatal myocardial infarction, coronary death, heart failure, and stroke, varying from 40 to 70% increase in risk if you are a diabetic. These are data from 1 million patients. So we're talking about a big, big cohort. Right, so before we go on, let's just deviate a bit to understand the role of the sodium glucose transporters, which you are all well aware of. Glucose is absorbed in the proximal convoluted tubule of the kidney, where 90% is absorbed, and that is absorbed due to the effects of the SGLT2 pathway. And then it titrates down, and then, so that accounts for 90%, and then the other 10% of glucose is absorbed in the distal pathway and probably some in the gut as well due to the SGLT1 transporters. So here you see in this cartoon an individual with diabetes filtering glucose. The glucose is high, it gets into the proximal tubule, and it's reabsorbed back into the bloodstream. So you do get some loss, but most of it is being absorbed into the bloodstream. If you add an SGLT2 inhibition, you block predominantly the proximal and distal absorption of glucose, which results in marked glycosuria and natriuresis. And it's the natriuresis, the loss of sodium, as well as glucose, which makes these drugs so important in the treatment of type 2 diabetes. So when we look at the efficacy of these drugs, we talk about MACE, which is the cardiovascular death rate, the non-fatal myocardial infarction, and non-fatal stroke, or MACE with heart failure or any other aspects. So the next 3 slides have a similar format. I'll go a little bit slowly with them. They look very busy, but I'll simplify them for you. So these are the cardiovascular outcome data on the GLP-1 receptor agonists, and this is lixisenatide, this is liraglutide or Saxenda, this is semaglutide, and this is exenatide, Bydureon, or Byetta. The mean ages are 60 years, the BMI is about 30%. They've had diabetes for 9 to 12 years with a follow-up of about 3 years. Statin use is high. Cardiovascular disease is high, so the inclusion criteria were in individuals with cardiovascular disease, and the HbA1cs varied from around about the 8 to 9%. And so if you look at the primary outcomes, that is the benefits for MACE reduction or cardiovascular death reduction or hospitalization for heart failure or worsening nephropathy, you see that lixisenatide didn't have any benefit. And in the red, you'll see liraglutide reduced MACE by approximately 12%. These are the hazard ratios, or 22% for cardiovascular death, and reduced worsening of nephropathy, again 22%. If you look at semaglutide, you again see the MACE reduction of approximately 26% and a striking reduction in the worsening of nephropathy by approximately 36%. And then in the exenatide, it was only able to achieve reduction in cardiovascular death of approximately 12%. So these figures are all statistically significant. They showed a positive outcome for GLP receptor agonist use in established cardiovascular disease, reducing risk, improving benefit, and so that made it past the FDA and is used as treatment for type 2 diabetes. If you look at the DPP4, the dipeptidase 4 inhibitors, just to remind you how these drugs work, GLP-1, endogenous GLP-1 is broken down by DPP4 to inactive GLP-1, so it causes indirect increase in endogenous GLP-1 levels as compared to exogenous GLP levels shown with the receptors. So this is mainly an improvement in endogenous GLP indirectly from DPP4. And there are 3 big studies, the saxagliptin, the allogliptin, and the sitagliptin study. Again, a similar cohort, 60 years, BMI 30%, diabetes duration 7 to 10 years, follow-up 2 years, statin use against 90%, and yeah, again, a cardiovascular study and HbA1c of 8%. And what you can see is this was a non-inferiority study. That is, there was no benefit, but there was no detrimental effect apart from saxagliptin, which did have a higher risk, a 27% risk of being admitted for congestive heart failure. And finally then, the SGLT2 inhibitors, and here we're looking at the EMPA-REGA study with empagliflozin, the declared TEMI with dapagliflozin, so empagliflozin being Jardiance, dapagliflozin Sgto, and then the Canvas, the canagliflozin study, which canagliflozin was withdrawn from Australia in Invokana, but the data is there. Again, the cohort is similar, 60 years plus, BMI 30%, diabetes duration 10+%, follow-up 4 years, statin use a little bit lower in the 70 to 75%. And again, a study where most of the patients had established cardiovascular disease. And so the HbA1c was average 8% throughout the study with a change of only 0.3% or 0.5%. I might go back to the previous slide. Again, you can see in the DPP4 that was 0.3%. So look, if we look at the outcome data, again, the MACE, the cardiovascular death, the congestive heart failure, hospitalization, and worsening nephropathy, you see empagliflozin has marked reduction in the outcome data with a 14% reduction in MACE, a 38% reduction in cardiovascular death, a 35% reduction in heart failure, and a 39% reduction in worsening of nephropathy. When we look at dapagliflozin, you see that the most striking features was the heart failure reduction by about 37%, as well as nephropathy. And in the Canvas, again, striking reductions in both MACE, 14%, 33% in the hospitalization, and 40% in nephropathy. So you can clearly see from these two studies, 4 studies that I've shown you, that both the GLP and the SGLT2 drugs are superior in decreasing cardiovascular and CKD outcomes. So this lady, what happened to her? She continued on her statins and ramipril. Dapagliflozin was added because of her cardiovascular kidney disease, and semaglutide was added with obesity, and she eventually underwent an insulin reduction program and achieved a weight loss of approximately 13 kilograms and a marked improvement in her HbA1c. And at the moment, she's on, I think, about 12 units of insulin a day, and I'll be stopping that soon. So what would you consider an ideal glycemic target for individuals with type 2 diabetes? And both the ADA and Diabetes Federation recommend an HbA1c of less than 7% or the IDF less than 6.5%. So what determines the HbA1c is that the lower the HbA1c goes, the more the total HbA1c value is determined by the postprandial plasma glucose. So initially when you're treating, you get these big reductions in HbA1c because of fasting, but it's the postprandial which drives it, and that's where the newer drugs are working. They are stopping the postprandial hyperglycemia because of their incretin effect. HbA1 targets should be either stringent, less than 6.5%, or less stringent, more than 8.5%, and that should be driven by the data of hypoglycemia, severe hypoglycemia, which was seen in the ACCORD study, where individuals actually died due to stricter glycemic control. And what this study shows is the risk of disease according to either duration of diabetes, BMI, or kidney function. So neuropathy is increased, and with duration of diabetes, the longer the duration of diabetes, the higher the risk over here. BM of the risk of hypoglycemia. BMI determinant, the fatter you are, the less risk you're going to have of having hypoglycemia compared to the thinner you are, the higher the risk. And that's where in thin individuals, you've got to be careful when you start adding therapies together because they have a higher risk. And then what about creatinine, kidney function? The worse the creatinine, the worse the kidney function, the higher the risk of hypoglycemia. That then led to the development of this kind of protocol, which suggests that you have stringent targets that is less than 7% or less stringent targets according to these underlying clinical conditions. If you have a high risk of hypoglycemia, less. If you have long duration of diabetes, less, because the risk of hypoglycemia. Individuals who are older, less. Many comorbidities, less. Vascular complications, less, lower HbA1c. People's attitudes and support. So all these on the far right, which are high risk for hypoglycemia, should have less stringent HbA1c measurements. So I'm going to end off on the last two slides to give you the ADA ESA conference statements on the management of diabetes. So first-line therapy is metformin and comprehensive lifestyle. And as I showed you in that first slide, if it's weight-driven, then the GLP-GIP must be the future for our management of patients. At the moment in Australia, we only have GLP-1 receptor agonists, but I'm sure within the next year or two, we'll have the combination. If that fails, you can add in the SGLT2s. If your risk is to minimize hypoglycemia, then and have the best outcomes and the HbA1c is above target, then again, GLP-1 combination is better, but otherwise the SGLT2s. And finally, in the third slide, we have the high risk atherosclerotic vascular disease, where I showed you that the GLP-1 or the GLP-1 predominantly had a marked reduction in cardiovascular outcomes. We're waiting, which will be, I think, in a year or two, for the combination drug to see what the CVOT outcomes are like. And then second line treatment with SGLT2 inhibitors. If it's heart failure, the slide I showed you specifically showed the benefits of both empagliflozin and dapagliflozin. So therefore, they are the first line choice of agents. And in individuals with CKD, less than 60 mils per minute, again, both agents have been proven benefit. The SGLT2s I showed you, the GLP-1s as well, but the GLP-1 starts to lose its efficacy when you start dropping an eGFR below 30 to 40. The outcome measure is in appropriate high-risk individuals with established type 2 diabetes. The decision to use these agents to reduce complication should be considered independent of the baseline HbA1c or the individualized HbA1c target, because these drugs, the GLPs and the SGLT2s, have such a lower risk of hypoglycemia and such an important benefit in reducing cardiovascular outcomes and CK disease that they should be considered almost first-line choice. And that, unfortunately, in this country is driven by PBS, which says it's got to be an add-on. But that is the future for the management of diabetes. So my summary is the following. Metformin plus other agents, you should not delay therapy. You should use metformin regardless of the HbA1c and provide independent cardiorenal protection. SGLT2 inhibitors, as I've shown you, have marked benefit in reducing renal deterioration and in heart failure. The GLP-1 receptor agonists have strong data for reducing atherosclerotic vascular disease according to the MACE targets. Combination GLP-1 SGLT2 therapies may go beyond cardiorenal protection, are very effective at lowering glucose and causing weight loss, and have a low risk of hypoglycemia. And finally, the factors for sequencing these therapies will really depend on the patient's preference, injectable or oral treatment, and the cost involved. So this just shows you, and I don't want you to look at the slide, you can look at it on the web later, but I've tabulated the different drugs in terms of their benefits in lowering the hypoglycemic risk, weight gain, euglycemic ketoacidosis, etc. So I thank you very much for listening to me.
Of contacting the clinical nurse consultant or nurses to get through to the department. Okay, it looks like we have another question. Can you comment about the off-license use of GLP-1 agnostics for weight loss?
I think it's effective. I've used it quite a lot. The two important factors is one, you can achieve up to a 10-kilogram weight loss because of its effect on decreasing satiety, decreasing gastric output, and improving insulin sensitivity. So it certainly causes the weight loss. The problem is that it has to be self-funded. I cannot see the government funding this in the future. However, I will give your audience my tip on how to use this drug. If you always start with 0.25 milligrams, then go to 0.5, and then to 1 milligram, slowly up titrating. The cost of the 0.25 and the 0.5 milligram pen, which is the same pen, is $120. The cost for the 1 milligram pen is also $120. The dispensing of the 1 milligram pen is made to dispense 1 milligram per week for 4 weeks, 4 doses, $120, 4 doses into $120 is $30 per week or $120 per month. Pretty expensive. But if you only give 0.25 milligrams of the Ozempic through the 1 milligram pen, it's going to last you 16 weeks, which means it's going to be $30 a month. The only catch is that when you dial up the 1 milligram, there is no markings for the 0.25 or the 0.5. However, the trick is that if you count the clicks, there's 76 clicks. So if you only count 18 clicks, it's 0.25. And if you count 36 clicks, it is 0.5. And so patients are very happy to pay $30 a month and starting on 0.25. And when they see it works, they're happy to pay $60. So they go to 0.5. And if it really works, they'd be happy to pay $120. So I think it's not on the PBS, but there's no reason why you people in general practice should not discuss that therapy for weight loss, because it is the only therapy available for weight loss which is effective besides bariatric surgery. And I suspect when the combined agent comes along, the bariatric surgeons are going to lose a lot of work.
Okay, thank you. We have another question. So who would be your ideal patient for tirzepatide, and when in the diabetes management pharmacotherapy pathway would it possibly be instituted if approved in Australia, for example, as initial therapy or after in combination with metformin?
Well, as I alluded to in my second slide, where we divided them into metabolic syndrome plus or minus and obesity plus or minus. The most important driving factor, I think, will be in the high-risk individual with atherosclerotic vascular disease and CKD. However, I'm putting tongue in cheek because we must wait for the cardiovascular outcome studies to show that, but I would be more than surprised if they do not better the GLP-1s. I think they will be too expensive initially for weight loss, even though effective. But if they can afford it, you would be using it in obesity. They're selling $1 billion a day in America.
Great, thank you. We've still got a couple more questions now coming through. Is there anyone you wouldn't give GLP-1 to?
Yeah, someone who's got gastroparesis from long-standing diabetes or has significant, GI outlet problems. Individuals who have significant renal disease, EGFR under 30, and those who cannot tolerate it because of the nausea. So those are and the fourth thing is obviously the cost. So those are the four most important things.
Yeah, we have another question. For the patients who have been on SUs for their diabetes management, what do you see regarding their use with the movement towards the new agents? Would you be removing the SU and changing over?
Well, the SU by itself was thought initially to cause increased cardiovascular death, but recent large non-randomized controlled trials are actually showing a benefit of the SUs. So my feeling is SUs have a definite place in therapy, especially individuals with, mild diabetes that are not that overweight, where you're combining it with metformin and you get adequate control. So that has to be the cheapest treatment. Is it the best treatment compared to the GLP-1s? No, probably not, but no one has compared that. However, what I do find is that when I have somebody who's on insulin, often I can withdraw the insulin by adding an SU with either the GLP-1 or SGLT2 therapies. So I think there's still a role for the sulfonylureas. The offset of weight gain is offset by the effect of the GLP, but there is a higher risk of hypoglycemia, and therefore you need to take that in mind according to the targets that I discussed and the underlying risk.
Okay, great, thank you. We also have another question that's come through. If a patient has T2DM for 20 years, 52-year-old, very reluctant to use insulin, HbA1c around 8 to 9 for years, no end organ complications yet, would you still aim for HbA1c under 7?
Did you say the age was in the 50s, or did you say the age was?
52.
Yeah, so that's a young individual. So, their risk of vascular disease may be 0, because there are some people who are protected and they might be a kind of a happy chappy, but they do have a high HbA1c, and so their risk is not going to go down with time, it's going to go up with time. So clearly that individual, you need to, and you see lots of them, they just refuse to take insulin and they run with those HbA1cs of 9, 10, 11, 12% on maximal conventional OHAs. And so in that individual, I would stop their treatment for 24, 48 hours and assess their HOMA and see if they have still quite significant beta cell function. Then you will win if you go to the newer drugs. Whereas if the beta cell function, because we're talking about 20 years, is very low, then these drugs, you're just going to waste your money because you'll never get the HbA1c down, and that these are really candidates for insulin because they've got beta cell failure.
Okay, thank you. We've still got a little bit of time. I see there's a couple of more questions. In the interim, what drugs would you use for CKD based on EGFR?
I take it that's in the context of type 2 diabetes with CKD. I think both certainly the SGLT2 inhibitors, EMPA and DAPA, have got great data in showing improvement or even a marked reduction in the progression of CKD, and GLP-1 also has that benefit, but it's probably easier for the patient initially to try the SGLT2 inhibitors.
Perfect. I think that looks like most of the questions that I could see come through. Thank you again for your presentation, Associate Professor Diamond.
Thank you and have a good day.
Thank you. I've just put the